Clinicians ordering an MRI want two things simultaneously: flawless anatomical detail and an image clear of any static. The laws of physics dictate they cannot have both. Every MR protocol requires the radiologist to balance three competing physical properties: high spatial resolution, signal-to-noise ratio, and overall scan time. Capture massive signal, but the resulting image lacks distinct borders. Prioritizing pristine resolution cuts off signal, flooding the image with static noise. MR image quality is a zero-sum physical economy, dictated by a single rigid geometric constraint. That constraint is the voxel, the physical three-dimensional box of tissue selected to capture proton signal. Mastering MR physics requires understanding exactly how the scanner console calculates the dimensions of this box and predicting the physical penalties that inevitably follow. We can construct this physical model by looking at the two-dimensional plane of an image, setting depth aside for a moment. The parameter governing the total macroscopic area of the patient's anatomy selected for imaging is the field of view. This diagram shows the field of view as a fixed boundary. That area is then subdivided by a digital grid known as the matrix. The physical area of a single resulting pixel is calculated by dividing the field of view by the parameters of that matrix. If we increase the matrix size from 256 to 512, but lock the field of view in a strictly fixed position, the individual pixels shrink. This provides a distinct diagnostic advantage: higher spatial resolution, which allows us to differentiate much finer anatomical details. But MR physics operates on a strict volume-to-signal ratio. A smaller physical pixel houses fewer target protons, meaning it captures inherently fewer photons. Shrinking the pixel to chase resolution starves the system of signal. The ratio of true anatomical data drops, and relative noise dominates the image. There is a secondary penalty in time. Increasing the matrix along the phase encoding direction requires the scanner to acquire more distinct signal echoes, dragging out the length of the scan. In the two-dimensional plane, any enhancement in spatial resolution achieved via the matrix is paid for directly through lost signal and increased acquisition time. In clinical practice, images are not two-dimensional. We have to introduce the z-axis, extruding the pixel into a 3D voxel. This parameter is the slice thickness, the physical depth of tissue excited by the scanner's radio frequency pulse. Increasing the slice thickness yields a massive, immediate increase in the signal-to-noise ratio, because a larger physical volume of protons is now contributing data to a single point. The geometrical consequence is that spatial resolution along the z-axis is severely degraded. This diagram illustrates the specific diagnostic danger of overly thick slices, known as the partial volume effect. Notice how a distinct lesion can be entirely encapsulated within a singular thick voxel block. Micropathologies can be completely masked if their specific signal is mathematically averaged together with a massive volume of surrounding normal tissue. Increasing slice thickness is the fastest way to rescue a noisy image, but it creates a dangerous diagnostic blind spot by hiding small lesions via volume averaging.
Beyond the internal dimensions of a single voxel, we must account for the macro interaction of multiple adjacent slices in a scanning sequence. Theoretical equations treat slice boundaries as perfect rectangles. Physical radiofrequency pulses, however, produce an excitation profile shaped like a Gaussian bell curve. Because these curves slope outward, their edges inevitably overlap with adjacent slices inside the patient. Protons in these overlapping boundary zones are prematurely excited and saturated by adjacent pulses. This creates an artifact called crosstalk. When the scanner finally attempts to read a specific slice, those previously saturated protons yield zero usable signal, destroying the image contrast in that region. The primary mechanical solution is inserting a slice gap between each acquisition, typically a void equal to 10 to 20% of the slice thickness. Another protocol solution utilizes non-contiguous interleaved slicing. The scanner acquires slices 1, 3, and 5 first, allowing the protons time to relax before the sequence returns for slices 2, 4, and 6. Managing the z-axis requires a constant compromise between the clinical need for continuous anatomical coverage and the physical reality of radiofrequency interference. This leads to the ultimate protocol dilemma. High spatial resolution requires tiny voxels, and tiny voxels inherently destroy the signal. How do we acquire a sharp image without being blinded by noise? The solution is repetitive acquisition, scanning the exact same K-space multiple times to build a statistical consensus of the true signal. This critical parameter is defined as the number of signal averages, or NEX. True anatomical signal is consistent, mathematically reinforcing itself over multiple passes. Random background noise is inconsistent and progressively cancels itself out. There is a severe mathematical bottleneck governing this process. Signal improvements scale only by the square root of the number of acquisitions. To achieve just double the signal-to-noise ratio, the scanner must complete 4 distinct acquisitions, multiplying the total scan time by a factor of 4. Time is the limiting currency in MRI. A radiologist can theoretically buy infinite signal for a high-resolution image, but the exponential cost in time makes it clinically unfeasible. 4 primary console parameters govern this voxel economy: matrix, field of view, slice thickness, and next. Increasing matrix, decreasing field of view, and using thinner slices maximizes resolution, but plummets the signal-to-noise ratio. Increasing next recovers that signal, but scan time shoots into the red. It is an inescapable logic loop. High resolution requires tiny voxels. Tiny voxels starve the signal. Recovering signal requires next, and next demands time. Pushing scan time to its limits introduces patient motion artifact. A slight physical movement will destroy the spatial resolution you just sacrificed everything to gain. There is no universal, perfect MR sequence. Technologists optimize for the specific pathology. They maximize spatial resolution to view a tiny cranial nerve, or maximize signal and speed to catch a bulky, moving liver mass. Mastery of MRI physics isn't in memorizing settings. It's understanding exactly which physical penalty you are choosing to accept every time you adjust the console.